Good evening, members. Good evening, everybody. First on the agenda is the apologies for absence. I have Councillor Murray and Councillor Prenter and Martin Cheeseman, who's from Health Watch. Substituting for those two councillors are Councillor Edwards and Councillor Van Dyke. There's also apologies from Councillor Richard Thorne and Councillor Thompson will be late. Is there any other apologies? No, thank you. That takes us to the record of the minutes. Can I sign them as a correct record? Yeah, thank you. There are no urgent matters. Is there any disclosable pecuniary interest or other significant interests? Or is there any whipping?
Yes. Yes, sorry.
I hope it's not whipping, but yes. Any interest?
No, just that I'm a public governor of the NHS Trust.
All right, thank you. Right. That takes us on to the first substantive item on the agenda, Medway NHS Foundation Trust update. This will be introduced by Alison Davis, Chief Medical Officer, who is here tonight for this item. Sorry, but before I get to you, I should just say how pleased we are on behalf of all of us that Jane Black's now the Chief Exec of Medway.
Thank you very much, and thank you, and I will pass on that congratulations. She sends her apologies for tonight. It's an absolute pleasure to be here. Some faces I recognise, and some new faces too, and nice to see one of our governors here as well. So just in terms of can you hear me? Let me just twiddle that round. Can you hear me now? Is that all right? Yeah. In terms of the background, so the last time we came to this committee to provide an update was in October, and at that time the leadership at the Trust had been lifted from inadequate to requires improvement by the CQC. That predates both Jane and myself and other executive colleagues, but we're very much on a journey of improvement to care for the community in Medway and Swale, and what I want to describe now is the work that's been done and is ongoing. So at that time, improvements have been noted in medical and care, old people's care, children and young people on our urgent and emergency services, which had been previously rated as inadequate. So the CQC came to inspect us again for our urgent and emergency care services in February of this year. The report was then released to us in June, and I've got to admit it was a secret that was very difficult to keep because we'd already had an initial feedback of the positive outcomes, but it's now in the public domain, and we're absolutely delighted that the significant improvements that we have made have been recognised by the CQC, and that this service was rated as good overall. There are very few emergency departments that are rated as good, and there are very, very few that will have been lifted two steps by the CQC from inadequate to good. They commended staff for managing infection control risks, which is particularly relevant in terms of COVID and the work we've done there, how we assess risk to patients and acting upon them. They praised the way that we cared for care was planned to meet the needs of the local population and individual needs of the patients who came to see us. They reported that staff felt respected, valued and supported, and were very much focused on the needs of patients receiving care. A number of improvements have been made since 2020, so just to highlight those, work with health partners in a collaborative approach to managing demand in our emergency department, particularly working with South East Coastal Ambulance Service, CCAM, so that we don't keep patients waiting in ambulances, and the target we use to measure is beyond 60 minutes. We work very, very hard to avoid any delays in handover for two reasons. One, it's obviously the right thing to do to get the patients into the department where they can receive the care that they need, and equally it's the right thing to do to release ambulances out into the community for patients to then have be brought in who are waiting at home. We've all heard about the delays that happen. So and certainly we are asked on a regular basis by the region how we've achieved what we have achieved, and we provide and help support other hospitals. So I think that's really, sometimes I think it's very important that as an organisation we remember to celebrate our successes as a learning organisation with always more to learn. We've opened, over the winter, we opened an additional 20 beds to cope with demand. We've got escalation areas. We're now working through shutting those escalation areas down, but having a really clear annual bed plan in process so that we can look after the patients we need to look after during the course of the year. This is all predicated by a multi-agency approach to timely discharge for our patients, and we are no different from any other NHS trust. We have a significant number of patients who are medically fit for discharge, who are within the hospital, who would be better off being cared for somewhere else. And that is a system-wide approach to resolving those issues, because it's not something as either in the community or as the hospital we can resolve independently. It was a real tribute to the hard work of the emergency department and a boost to their morale. Nevertheless, there's always more work to be done, and we intend to get to outstanding for all of our services. In terms of moving on, in terms of performance, the emergency department, we've had particularly high levels of attendance during the summer, which is perhaps unexpected, which has led to longer waiting times than we would wish, and we would want to note that we want to apologise to our patients whose experience have been affected by as a result of long waits. It's something none of us would want, and we're working through that together. We've instigated a focus on ensuring patients are seen, admitted and discharged within 4 hours, which is a constitutional standard, using an electronic patient tracking list. The pressure on the emergency department is not only linked to an increased attendance, but higher than previously. So what we've said is acuity of patients, and what I mean by that is patients who attend are unwell. It's not lots of patients attending necessarily because ED is the only place, emergency department is the only place to go. These are genuinely unwell patients who take considerable time for them to have the care that they need. In terms of other work that we're doing, there's something in here which is described as the Hospital Ambulance Reception Improvement System, or HARRIS. The HARRIS programme is looking at, from a national perspective, we are working with NHS England in improvement to ensure that we can be an innovative organisation, and we have been commended again nationally for the work that we've been undertaking, but as well as the ambulance handover, there's putting in place a better approach to managing acutely medically unwell patients, and also the use of virtual wards. So that's all within that national programme. In terms of elective surgery, we've worked very hard to reduce waiting times and have made good progress, but further waves of COVID since we last reported to this committee in October have meant that these delays have been setbacks. But the approach we have taken is to use capacity within private providers, working with commissioners to support pathways for specialties that are more challenged, and then looking at additional bed capacity outside of the acute hospital to free capacity, so that we only have patients who need to be on the acute site in the hospital, and if there are appropriate patients to move to appropriate areas, then that is a key piece of our work. We're very pleased that we've dramatically reduced the number of patients waiting for more than 52 weeks for surgery, and we're certainly ahead in terms of other providers across the region in doing that. Our next step is to reduce waiting times for patients who are waiting for more than 40 weeks, and gradually we work our way down. You remember the 18-week target for patients requiring treatment eventually, but we're just working in a stepwise approach. And I think by way of assurance, I'd want to note that all of the patients who are waiting, there's a risk assessment and carried out, so that patients at our highest risk are treated whilst we work through the backlog. In terms of cancer performance, this is another highlight which you may have seen in the national press. We've absolutely prioritised maintaining and delivering to the constitutional mandatory standards for patients with cancer, particularly the 62-day from GP referral for 62 days from the GP referral, and achieve that for the first time in nearly 3 years. I think I want to highlight here, not only have we achieved this, but we are, again, exemplary in the work that's been undertaken, and we are certainly within the top 10% of nationally being able to achieve the cancer targets. And I think when we think about the area that we serve and the population and the deprivation, that really is very, very important, to the extent that we were regional winners in parliamentary awards for our cancer team and the work that they've done. We're certainly not resting on our laurels. In terms of diagnostics, we're working very hard to improve endoscopy and MRI scanning, because the diagnostic pathways are not swift enough to enable us to then move patients onto the treatment plans that they need. I'm going to slightly pause for breath. In terms of I think one of the key things that is absolutely crucial that's been developed since last October is patient first. Patient first is the trust strategy, and what that means is providing the best treatment for our patients by the best people every time. It's what, as clinicians and colleagues working across health, we get out of bed in the morning to put our patients first. So it is absolutely how we are approaching all our quality improvement, and there isn't anything else. It is the trust strategy. It's been used in other trusts, and Jane, who's our new CEO, has experience of using this in Sussex, as George Finley, her predecessor, did. It's centred around developing a culture of continuous improvement. It's led by frontline staff. It's bottom up rather than top down in that regard. One of the things I particularly like about it is that it focuses on, rather than a mile wide, which is what we all tend to have. We've got multiple projects, and we're all spinning plates furiously to try and maintain all the improvement work. It's a mile deep and an inch wide. So bringing a focus and saying these are the things that are going to absolutely make the biggest difference, and we will focus on those. That means, therefore, there are other things we won't be doing, but we monitor those and we watch those in case they need focus as well. We're in the process of now rolling that programme out. There are 4 wards that have been identified as the first areas to work in the Patient First programme, in terms of focusing on the recommendation rate from the Friends and Family Test, because we felt that that was a key area that we wanted to focus on first. But the improvement programme, there is something for all of us in the organisation to be part of. So, for example, I am responsible for the quality domain, which links to mortality. Sadly, patients do die with us when they're in hospital, and what we can do to prevent that. And all of us as executives have domains for which we are responsible, and working with different teams within the organisation. So it's actually a sort of almost like a complex matrix, which becomes our way of being. I think I'm going to stop there, apart from say there are no financial or legal implications for the council, just to note that. But I think I just want to leave you with three thoughts. We are on an improvement journey. Significant progress has been made and is demonstrable since last October to care for the patients of the communities of Medway and Swale. And I want to thank everybody. I've been here since January, and it's been an absolute pleasure working in Medway and Swale. I've been made to feel very, very welcome, and I've been taken on a tour of the area, so I can understand where the patients are that we're caring for and live in their communities. Patient First is the trust strategy. There is nothing else. It's the way we are. And just to leave you with the highlights of the CQC Emergency Department reaching the good the good outcome that was noted, and also our cancer performance, which is exemplary, and what the population of Medway and Swale deserve. Thank you.
Thank you. And I'm sure we're all pleased that you've gone from inadequate to good in the emergency department. And whether it's very rare or not, we hope you make even better. So, thank you.
Thank you.
Councillor MacDonald.
Thank you, Chair, and thank you, Alison. First of all, welcome, obviously. What I'm about to say is I was going to say it's a shame that Jane isn't here. That doesn't mean that I'm not glad to see you here, so I just wanted to make sure. But hopefully Jane will attend others, because we always did have the CEO attending these meetings, and hopefully she will be at the next one for us to be able to ask. And obviously, congratulations to the Trust and your frontline workers, especially after, I know we don't always want to go back, but especially after the COVID period and stuff, and with exhaustion and the morale, they've done an amazing job to get that rating, so well done for that. One of the questions, it's very difficult because a few of the questions I had was aimed at Jane. So I presume you'll take them back, or you might be able to answer some. But the first one being is obviously Jane is the 4th CEO in the last 4 years we've had around this table. And I suppose I would ask you for reassurance. It's very difficult, I know, but maybe we'd ask Jane when she comes next time, is for that reassurance that she understands the need for sustainability and stability, and to hopefully stay in the job. Sorry, I can stop after everyone, Alison, if it's easy enough, because I have a few questions. But I hope she does understand that there's a big challenge still ahead in that hospital, and you know we really do need stability there. So I welcome her to the role, obviously, but I hope she understands that that's really important, not just for the Trust, but for the community that, as you said, the Trust serves. And, you know, you are busting at the seams with regards to people trying to access service in the hospital. Even though the rating's good in the emergency ward, etc., people are still waiting long waiting times to be seen. And that's partly, I think, due to your GP services and your external primary care. The other thing that's missing from the report is the staff morale and survey. It was something that we was very keen on here, and Councillor Purdy will remember we used to always ask about staff morale, and we used to get full reports on that, and we used to try and see whether the rating was going up about the response, or whether there was a good response, because if there was a low response, we tended to then feel that maybe staff weren't engaging. So if not now, I mean, you can tell us a little bit about that and about the surveys you're doing, but hopefully we can get some data or some recent data from your surveys you've done across the Trust with regards to the staff. Like I say, I think that's really important because, you know, from the outside we hear morale is quite low at times because of being exhausted and because of being tired, but it'd be good to see, especially when there's a change of leadership, it'd be good to see how that impacts. I'm not saying George didn't bring the morale up, but I still feel there might be an issue, because there was for some time, there might be still an issue with morale. In the point, on 4.3, you said that the work, Jane said in the report, that the work is going well with partners to ensure packages of care is in place. I'd like to know how well that's going. If so, when I read that, it's almost telling me that everything with social services is great, which I hope it is. There's no blocking at all, there's no chaos, but there isn't much detail in the report to tell me anything different. So, if not now, I would like to know how that partnership is going and what new ways of working maybe Jane will bring into the practice with the social services team to ensure that all their packages are in place. Because all I tend to get is people not getting their packages put in place properly, and that isn't even necessarily the fault of each partner. Sometimes it's the fault of the system, and that's why they're waiting so long to be released, etc. The final one for me is patient first. I always shudder a little bit when you hear something new, and it isn't a criticism, again, and the committee here, no, I don't criticise the health service, because coming from it myself, I'm very passionate about the health service. But when I hear new innovative names and ideas, it worries me somewhat, because when James was in, as the committee would agree again, we had all these new wonderful acronyms and new ways of we were going to work with all the staff, and then George has come in now. I think you said George brought this new one, inpatient first, so it's probably being carried on hopefully, but you know, putting a name to something doesn't always change the problem, or doesn't always change the initial issue that you might have had within the walls, etc. I'm not saying it's not a great idea, But I would just like some reassurance around, is it going to be around for long or will it be changed again? A bit like the new CCG.
Couldn't possibly comment.
No, I know you couldn't, I can. But, you know, a little bit of reassurance that isn't just another wonderful new thing coming out that, that will only be here for a little while and then you'll change it again in a few months' time. So, is that okay?
Right,
Thanks, Chair.
okay. Right, I'll go back. So, I think I've written them down. So, yeah, I'm sure Jane will be here for future meetings. She was on annual leave today, so I'm sure she'd be very happy to have an individual conversation, one-to-one, whatever would be most helpful. You know, everybody's very welcome to come and walk around and talk to us. So very happy. I'm sure I will take these questions back just to make sure. But in terms of continuity and leadership, absolutely hear and understand that. I think that Jane she is her own person, she would be the first person to say that, but she does bring continuity because she has been within the organisation, Medway, for some time, firstly with her NHS England and improvement role, and then as our Chief Operating Officer working. So actually, from that perspective, once there was going to be a change, actually this is a very good outcome in terms of stability and continuity. In terms of staff morale, we have an annual staff survey, and in the next report we can provide an update. It is what it says on the tin, it's annual, and it's always it's reported several months after the event, so it's always one of those things, it's always a bit tricky. But nevertheless, there are really important points that come out of that. And we know that our staff morale as a result of coming out of COVID and all the things that have been happening is not where we want it to be. There are areas, you know, if I go into ED, for example, there's now an absolute buzz. Can I say absolutely hand on heart that that's across the whole of the hospital? No, it isn't. But I think it's about recognising that, and I'll come to patient first in a moment, but one of the things that one of the domains in Patient First is around that whole staff piece, and one of the things we're looking at is how we can capture how staff are feeling in a way that is more than once a year. And so different ways and different thoughts around that, whether it be through, you know, appraisals, regular touch points. But I think that it's for all of us as leaders to recognise that there's lots and lots of work to do in this area, and in terms of the whole well-being and what that actually really means. It's not just one thing. There's, you know, workforce shortages that we need to resolve. It's how we talk to each other, that sort of cultural piece. And, you know, people say it takes a long time to change culture. My reflection on that is actually all of us can start changing culture immediately. How I behave to my colleagues, how my colleagues behave to me, actually sets quite a significant tone across the organisation. So, yes, whilst it's the staff morale is not as I would wish it to be, there are pockets where things are very definitely better than others, and it's us understanding where the pockets are and providing well-being support that's tailored, so it's not a one-size-fits-all. In terms of packages of care, similarly, I wouldn't like you to read this and think it's all sweetness and light. It's not. There is a lot, we know, a significant number of the patients who are waiting to go to onward from the hospital who are medically fit and ready for discharge are waiting for packages of care, and we're working across the system with community colleagues and working collaboratively to find how we can make that better. I think one of the highlights for me was when I was walking around the wards recently, and I was just chatting to a lady sitting in a wheelchair, and I was just sort of said, how are you, and things, and she said, well, I'm fine. And if you looked at her sitting in a wheelchair, she was fine. She said, I want to go home. And I said, I want you to go home. She said, but I can't, because I can't go back to my flat, and there isn't anywhere else for me to go. So, you know, there's a very good video, which I don't want to say it's on YouTube. It's called the Last 1,000 Days, and actually a lot of our patients, you know, they are entering that phase of their life. We want to ensure that they spend the minimum amount of time possible in hospital, because it's not, you know, for all of us, none of us want to be in hospital. But yes, I wouldn't like you to read that. What I would like you to read from this is that we are working on this together across the system. Patient first, yes, I get that, acronyms and all the rest of it. I think what I would say is that actually this resonates with clinical staff. of all the quality, because as I said, it's what we get out of bed every day. It's what I do as a doctor. I get out of bed every day to make things better for patients. So I think it resonates, and from my own experience, another acronym, sorry, Getting It Right First Time Programme, the GIRF National Programme. I'm a national co-lead for ophthalmology. I have been for many years. One of the reasons I came to Medway was because of Patient First, because I can actually see it resonates with everything I've been doing nationally for a long time. It's predicated on data and focusing on specific things, which is exactly what Getting It Right First Time is all about. So I don't see it as, I see it almost, Patient First, as a consolidation, which all the things I know, I've been a doctor for a very long time, it's actually consolidating what I think is the right thing to do. Yes, it's got a name and so on and so forth. But actually, when you peel away the layers, there isn't anything other than that this is clinically the right thing to do.
Thank you so much for that. Just on the staff survey, the staff wellbeing, Glyn's not part of it, but we'll remember that there was mechanisms in place because of bullying and because of other bits and pieces that was happening before. There was mechanisms in place to make sure that was being really spotted very early and effectively. So it wasn't just the annual survey. There was I forget what James used to call them, the wellbeing chats. Used to go and have these chats with staff every now and again. Can we be assured that that's sort of in place still, that you are keeping an eye out for anything like that is still in place?
Absolutely. And we're very clear, and what behaviours the trust does have values and what the behaviours are, and it's that we all treat people well, we treat people kindly, and if we have differing opinions, we talk it through, and I think you can have all the processes in place, but it's how you live and breathe it that's important.
Thank you. Just briefly, I know Jane has met with me at least 3 times. I know Councillor Murray once, and I believe Councillor Purdy twice, maybe 3 times as well. So, yes, so she is very available to meet us, and she has suggested that in small groups we can visit the hospital. But oh, of course, yes, yeah. But she's making herself more available than some of her predecessors.
You're very welcome, is the short answer.
Thank you. Councillor Purdy.
Okay, thank you. Actually, Dan has touched on some of the points that I want, because, of course, staff well-being is extremely important, and I think we've all been in agreement that it isn't something that you can have once a year and think it's a daily thing, and things can change. But I think you've answered that question and satisfied that there will be something done. And you also loosely answered what I was looking at 4.5, page 17, where you say, we are also looking at other projects to support patients who do not need to be in bed within the acute hospital. You couldn't highlight a bit more on that, how you are actually tackling that problem?
So I think it's a variety of things. Some of the things we've talked about, which are the patients who need to be in their own homes with packages of care, patients who need to be in care, residential care, whatever that might be. We are looking at how we can develop, and I think this has been discussed before, around programmes to Minster and the Minster work that we're doing there, which will be for all patients across the system. And I think for me it's something about as well how we, and not just for me, but the work we're doing is around assessment. What we know is that patients who are seen and come into hospital, actually there are alternatives, and if we assess patients appropriately with the correct resources in place, that they can have appropriate care outside the hospital, be that in coming back to outpatient appointments, to being seen and assessed. Our frailty assessment unit is a really good case in point when we're just getting that up and working again post-COVID. But it provides an opportunity for patients to come have treatment and then have not be admitted to hospital.
Can I come back on that? So what you're saying is you're trying to improve care. Robbie, could you sit back just a little bit? You're very handsome, but I can't see through your head. I've put myself off now. I don't know what I'm going to say. It's care in the community still, isn't it? That you're actually working on. Is that what you're saying?
I think what I'm saying is care across the system.
Yes.
So it's us. I think what we are talking about is that, and I'm sort of looking at colleagues in terms of it's that care, it's that relationship between us and the community, between health and social care. Neither of us can do what we want to do well unless we work together. So it's not either or. It's us across patient pathways. And I think for me as a clinician, it's starting with, okay, what's the right thing for the patient? Where is the patient pathway? Therefore, what is the right approach to caring for that individual patient? So I think that in terms of perhaps the continuity of work that had been started previously with George and Jane is continuing with, is that reaching out beyond the hospital. So we have an absolute obligation to do the things we can within the hospital, of course we do, but there are some things which are out with that, but it's no good as everybody saying, well, this is your problem, this is my problem, and never the twain shall meet. It's actually how do we work together to find the right solutions.
I think that's very refreshing, because you don't discharge somebody, take them home, leave them in the doorstep or put them in the home and say thank you very much. You will be following that through to see that they're getting the right care. Yeah, because
absolutely.
that's where we have fallen down greatly with that.
And one of the other points within the Patient First programme and the approach we're taking is patients being discharged before noon, because actually we want to get patients back to where they need to be in a timely way. We know that we don't achieve that as we would want to, and that's going to be one of the real focuses with Patient First.
Right, thank you. Jackie Brown would like to come in.
Thank you. I just wanted to sort of give some reassurance around how we are working with MFT and with Medway Community Healthcare. There is an issue and there are real challenges with the provider market, care generally across the board for adult social care, and we know it is for children's services as well. And, I could sit and talk about numbers of people in the community that are waiting for care and numbers of people that are waiting to come out of MFT. I think the reassurances, and they are very regular meetings that we have. I mean, in fact, we're meeting tomorrow afternoon. We have daily meetings to talk about patients that are being discharged, and they're multidisciplinary meetings, so colleagues from different, MFT, Virgin, MCH, ourselves, KCC. And what we've done in Medway Council is we've had to reframe the way that we are working slightly because of funding ending around discharge to assess. But that means that social care are actually looking at the most appropriate care for somebody that is discharged. So if it's a brand new package of care, an increase in care, to go into a care home, and we're working with people to look at, if it's a care home, it's their forever home rather than people being moved around. But to say that there aren't challenges with care, I mean, absolutely agree with Alison, but working with partnership commissioning, we're looking at alternatives, how we can onboard new providers and so on and so forth. There's a lot of work taking place across Kent and Medway, but it isn't an easy change, I'm afraid, unfortunately.
I'll accept that, Jackie. It isn't easy, and I do know that. But we have to remember there are a lot of people out there that get very frightened that mum or dad or whatever it is, wife, where will they go? What will they do? We can't cope with them at home. The homes aren't always available, places in homes. So I do think it's something that we've got to work extremely hard on. But I am glad that the hospital and Medway Council will, and there are other lots, as you say, MCH, so we've got a lot of partner people to do, but there's a lot of work to be done, and I do understand that. But when I'm talking to people, I like to be able to reassure them that we haven't forgotten about them.
Right, thank you. And for the cameras, Jackie is the Assistant Director for Adult Health, Social Care, sorry. With that, Councillor Lammas.
Thank you, Chair. And can I thank Councillor Wendy for her compliment earlier? Can I just, this is a point for all meetings. I don't know if it's possible, but I would prefer if all guests were centrally positioned here so that people can see them better and address them rather than tagged on at the end. So, and it also helps with the line of sight. You're also very beautiful too, so thank you very much. Love you too. I have a few questions for you, if I may. The first one is on data. I appreciate this report, and it's very positive, but for me, it's lacking in data. I know this data is available. I've looked at the data online in different places, but where you say a reduction in the number of patients waiting in ambulances longer than 60 minutes, how big is that reduction? Put some data to it. Over the summer, the trust has experienced high levels of demand with attendances in the emergency department above what it expected. How much above? How does that compare with other comparable trusts? I know this data exists in many spaces, and this is a concise report, but I would appreciate just a bit more data. So if you have any data, I would appreciate it. The second question is about speed of improvement, Chair. I'm really quite surprised that we've gone 2020 inadequate, 2021 requires improvement, 2022 good. So in 3 years, we've gone 3 steps up the full Monty. Yet, during that same period of time, population pressures in Medway have got worse, not better. The mental health impact of COVID has been borne out, which it wasn't at the start when inadequate was given at the rating. And GP accessibility has significantly worsened over that period of time. So I'm really surprised how our hospital can go from inadequate to good in the space of 2 years when all of the pressures that exist, which I think are predominantly there hindering the hospital's improvement, remain. So to that end, what confidence do you have in this assessment process that these things aren't just looking for what they're looking for, they actually assess what is actually going on? And the third final question I have for you is that if it is the case that it is all down just to leadership, and it's taken 3 years to see this huge turnaround, which is remarkable in spite of the population pressures remaining the same, is your target for 2023 to complete the full Monty and go for outstanding so that we can go up one each year? Because it would be awfully horrible if you couldn't do that, because it would make it very unneat. Thank you.
Thank you for your confidence, I would say. Maybe if I go to the last question first. In terms of the trajectory, I think, thank you, it is a remarkable change in terms of how the CQC they are our regulators. They determine how they inspect. The approach that we have is that we do the right thing for patients because it's the right thing to do. And when the CQC come, they see the work that we've done, and they will rate us accordingly. I think in terms of the CQC inspection timeline is what it is. I wouldn't like to say, now we've got that good rating for our emergency department. Because of all the challenges and pressures outside Medway across the country, I wouldn't like to think that the CQC probably won't come and visit us again next year. I'd be very surprised if they did. So we're not going to be able to complete the trajectory that every year there is an improvement. But in a way, the CQC come in whether they do or they don't. This is part of us improving our services. And again, it goes back to that, what can we do within the hospital to make things as good as we can, and what is it that we need to do working across with the system, with system partners to make things better. So the journey of improvement will continue. Whether or not we get another CQC visit to change the rating will be what it will be. In terms of data, I think that's a really helpful feedback, so thank you. In terms of the specifics around ambulance handovers, we've had, we monitor this very closely in terms of the absolute numbers. I was trying to think the best way. We've had an increased number of ambulance handovers over 60 minutes whilst we had that very busy period in July. That's now tailed off, so that we're looking at, when I say very small numbers per day. So anyone is out, we go back and we monitor. But in terms of giving the absolute data and the absolute numbers, I think what would be useful is we take that away and we'll bring back, when we do this report again, we'll put in more data for you, so it's absolutely clear. And I think that probably answers all 3 of your questions in 2. Is there anything else specifically you wanted to ask?
It's just I just can't. Is it the fact that these changes have manifestly taken place, and Medway Hospital is a completely different place than it was years ago, and all of these external pressures on the hospital, people can't see the GP, they turn up at the emergency department and suddenly gone away? So, or is it the fact that, well, I'm reassured by your answer. What you're saying is you're doing what you're going to do anyway and improve the hospital. CQC can monitor and measure what they like. they can see us in our best light. That's basically your answer, isn't it?
Yeah, and I think that in terms of the work that has been, there's been lots of good work that's been underway for some time, and in a way, as a leadership team, it's been pulling together the good parts and amplifying them, and actually listening. So to where there have been concerns and doing something about it. So, for example, Jane and I and colleagues, we try and go to the ED department. One of us goes to, as execs, when we're on site, we go to ED every day. To the extent now that, when I'm on holiday, they now say to me, Alison, where have you been? And I say, well, I am allowed to go away because they haven't seen me for a bit. But it's that sort of, I think it's those sorts of things. It's not us as leaders, as executives in that. It's how the team working together on the ground, pull together, work together with our support to improve. And that's now is part of, as I say, that is just how we do things around here at Medway.
Okay, thank you. Councillor Price.
Yeah, thank you very much, Alison, and also value a very warm welcome to Jane Black. Obviously, she was in an interim role anyway, but now she's got the substantive appointment. My first question is the fact that almost all NHS trusts, including Medway Foundation Trust, are missing waiting time and treatment targets, and there were some latest figures out just last week. How will Jane and her colleagues ensure Medway Foundation Trust get that to target? Because obviously for our residents in the area, it is things like waiting time and treatment which does matter to them. And then my second question, I'm one of the councillors who is serving on the GP task group, which we've got at the moment, which is a council-like initiative. So locally, the shortage of GP appointments is putting pressure on the hospital with long queues at A&E, and that was being alluded to earlier on. So we have this council task group on GP appointments now, but also I know that the hospital is working hard at its triage, and the hospital does take a determined approach towards turning people around at the door, not just turning them around, but pointing them towards community-based services, which is excellent. However, my question is this approach like sustainable, and what will Jane and her colleagues do in order to take the pressure off? So that's the pressure on like primary care, and due to the pressure on primary care, you're getting that much more pressure on your doorstep. Thank you.
Yeah, no, and thank you for those questions. I think in terms of waiting times, yes, we all recognise that patients are waiting too long for treatment, and it's in terms of the approach we're taking, it's a risk-based. First of all, it's a risk-based approach, so ensuring that patients who have the greatest need have the treatment that they require first, which does mean that some patients end up waiting longer than we would wish. And in the paper, I talked about how we're now having achieved the 52-week waiting time and having no patients waiting for longer than 52 weeks. We're now focusing and moving gradually down. We're now at 40, and that will gradually work its way down. I think from a clinical perspective, what we're doing is looking at, again, patient pathways and how we can use what is known about clinical best practice to bring that where we are already achieving best practice. We celebrate that, and we get other teams to look at what they're doing, and where we know that there are opportunities because there are clearly delineated best practice pathways. And my own work with the Getting It Right First Time programme nationally, then we pull those into the organisation so that whatever we do, we're doing it in the best way possible, recognising the backlog that we're having to accommodate because of COVID that has built up. And I think in terms of GPs, yes, I think again it goes back to we could all sit with our arms folded looking slightly grumpy about, well, is it us, is it GPs, is it who is it? But actually it goes back to us all working together. We have, with the triage process, we're very fortunate we have Medoc on site. I meet regularly with Simon Collins, who's the medical director of Medoc, to work through what we can usefully do together. I know that we have GP trainees with us in the hospital. James and I were just talking about this earlier. We do all we can to make sure they have a positive experience in Medway, because I want Medway to be like glue. Once you arrive, you don't leave professionally. You stay and want to work with us. And I think there's ongoing work that we need to do to really highlight the significant opportunities for working medically and from a nursing perspective, and allied health professionals, so the whole clinical team. There's absolute value in working in Medway, and how we can highlight not only is Medway a great place to work and have from a professional perspective, but how it's a great place to live as well. So I was a South London resident for 30 years. I'm not quite sure what took me so long to move to Medway, but I'm very glad I did a year ago, and I wouldn't recommend to anyone commuting on the Northern Line for 2 hours a day.
Right, so if I may, Chair, just sort of going back to the first point, and I was very pleased to hear about the good practice which is being achieved in terms of being able to bring down some of those times, and that being shared like around the trust, and that must be quite a powerful motivator as well, because I should imagine that there must be staff from all sorts of different disciplines who are involved in that, and if you can encourage that team approach, and it must be a very good like motivator towards like morale. And like how do you share that? Is it just through written newsletters, or is it through team sort of feedback, like etc.?
A variety of ways. Glynis is sitting there, but comms is all our business. So through, I think, regular communications, we have Jane and has a weekly chief executive briefing. We always celebrate the success and the highlights through that. We have we have team awards, employee awards, and those types of things we share through sort of whatever domains we can in terms of communication out with the organisation. We have teams coming presenting at the public part of the board on a regular basis. I and all of my exec colleagues, whenever we hear about something that's good somewhere and we think, well, actually somebody else could share that experience and learn from that, we make those connections. So it's invariably, if you've got an issue, somebody else somewhere probably has found a solution, whether that's internally, looking across Kent and Medway. I'm very clear that we benchmark nationally. That's my experience from previous roles, and I expect us to be able to benchmark nationally, working collaboratively across Kent and Medway.
Thank you, Adam. Councillor Van Dijk.
Thank you.
Excuse me, your microphone's not.
Gone off again. Is that working now?
Yeah, lovely, thank you.
Yeah. So on page 17 of the report 4.3, it states the pressure on the emergency department is not only related to increased attendance and the higher than usual acuity, put my glasses on, of patients, but also a poor discharge profile in the hospital. And so going back to my original question that I wanted to ask is about how patient first works to achieve the improvements that are needed in order to move people on. But the main part of the question is the new ICP for Kent Medway is now up and running. And does the Trust have confidence and commitment in the partnership working that the ICP is supposed to bring, especially when it comes to the stresses on social care, which is challenging the council? So it's about how those other partners within the wider health service are going to help you to achieve your goals in moving patients on.
Thank you, and thank you for both of those questions. Patient first, and that whole point about flow through the hospital, it absolutely does. It's one of the key domains within the work that we're doing. So I mentioned the home before noon and getting patients to where they need to be earlier in the day, because we know that we have we have a significant broadly, we have enough discharges a day to be able to accommodate the patients that need to come in, but they occur too late in the day. So the absolute focus on what can we do to bring that forward. And equally, there's work going on around length of stay, and we've already heard colleagues talking about how we're working with the council and the community to work together. In terms of confidence, in terms of everybody working together, I think that there's a real... And this is perhaps me coming at this with fresh eyes. So sometimes there's an advantage in new people arriving. But I would say that I have been very heartened by the enthusiasm that I've seen in the time that I've been at Medway, which is since January, about people wanting to work together and actually seeing that we are all in it together. I think, like all relationships, they take time to build and they need to be maintained. But I'm confident that we are, and I'm sure Jane would say the same, we're confident that we are engaged together and from our different, it's bringing to the conversation our differing perspectives and experience to work together. So in terms of assurance, I would want to assure you that I think that the relationships and the commitment and working together is developing. It is something that we all need to continue to work at to achieve what we want to.
So is that across the whole health community? That's my question, really, because I probably know a bit more about what's happening in the trust, but it's about the relationship with those other partners within the health family in terms of primary care.
Yeah, I think, yes, I would say so. I think there's lots and lots and lots of work to do, but I think the fact that we're all openly having these conversations and prepared, saying, well, what is it? It's not there's very much this is our collective issue, and how do we find solutions together, rather than people saying, well, this is your problem, this is that isn't the conversation that happens at all. So yeah, I think that we're in the right place to make these types of improvements, working at a system, across a system, with our patients at the centre of our being and what we do. I think it's fair to say it's all relatively early in terms of, and I think going back to the point around data, the data will be what will show the difference, and that's what Patient First is all about. Is about data. So that will be, I think, the assurance that collectively we all know that we're making a difference, and where we're not making the difference we would like to make, what we're going to do next. Doctor.
Thank you. Just a comment, as Councillor Van Dijk's new, I'm sure other councillors that aren't so new heard very similar things when the PCT took over, when the CCG took over, and now the ICS, ICB, etc. So I hope you're right, but I wait to be convinced more than have any great faith, to be honest. Councillor Turpin.
Thank you, Chair, and thank you, Alison, for bringing this report here this evening. First, there's a lot of good news in this report, and in particular, well done on the improvements with the emergency department. And, often the proof is in the pudding, and it's not something that we ever want to have to test out. But I will say I have to call an ambulance for my son very recently, and the service I got from the moment the paramedic arrived, which is incredibly quickly, to his treatment through the emergency department going on to a London hospital, was fantastic. So please do pass on my thanks to the team. It was most appreciated. Just going on to the sort of also the improvements with sort of cancer patients, and just sort of firstly just a sort of a small question on regards to the treatment, because I noticed it's sort of 2 weeks to be seen, and then sort of another 2 weeks to get a diagnosis is a target, and then the 62 days, so another 2 months to sort of start treatment. Is that across the board with all cancers that are diagnosed? Is there any exceptions? There's no sort of, this is not as serious, so this can go on a different kind of list?
No, these are the national standards.
Okay, and I guess sort of, it's a great positive. I just wanted to sort of ask you whether you think that the efforts that have sort of been put into this and to the ED, do you think that's to any detriment to other parts of the hospital? That's what concerns me, that will we sort of at a later report in months' time sort of hear about other services within the hospital that have suffered as a result of all the efforts and no doubt the financial implications that have been put into these. So sorry to sort of bring a negative to something that's very positive. And just lastly, sort of a point that's been made on the patient first from other members. I just sort of want to know what, because when I sort of read through this, I was similar to probably Councillor MacDonald, kind of had my concerns over it and a point of, isn't this what hospital should always have been doing? You know, shouldn't it always be putting patients first? Why do we have to have a sort of particular initiative? So I just want to know how you think this, what changes do you think will come about because of this? How do you think the hospital and the departments will be doing things differently because of this actual initiative? Thank you.
I think in terms of your first point, I think Medway is no different to many other hospitals, and lots of hospitals I've visited across the country from my other national roles. There is already excellent work going on in Medway. So by way of example, things I haven't talked about, fetal medicine, for example, maternity, ITU. There is lots of good practice already. What I think we're highlighting here is perhaps the things that actually are really difficult to achieve, and that again goes back to we carry on doing everything. Where there are areas that really require significant improvement because we know they're going to make the biggest impact for patients, we have to have a focus. We're duty bound, we're obligated to do that, but that doesn't mean to say other areas are not. We have regulatory requirements, we have there are always opportunities for doing, and that's when I talked about patient first, that there is some within the way and the structure and the approach. It's for all of us. It's not just for the forward, the initial rollout. It's for all of us all the time. Yes, you're quite right. You would say, well, shouldn't we? No, it's a bit puzzling. Why wouldn't we do this anyway? I think what is different for me that I really think resonates is we work out where, using data, we need to focus to make the biggest difference. And that's what we do, rather than, as I was sort of alluded to, as within any organisation anyway, there can be, you end up with multiple projects going on all across the same time. And so you end up not quite achieving anything, and you don't actually focus on what's going to make the biggest difference first to make the important changes. So yes, there is a judgment and a balance. And as we work our way through the organisation, different areas will have that focus and priority. I think what is the other thing that's perhaps different is the way that Patient First it's about empowering frontline staff to do the right thing, because I think lots of organisations, sometimes things can be distinct and not removed from where people working very close to work on the front line don't feel empowered to make the changes, and I think that's one of the real key benefits of this. But no, I absolutely agree, and I think the reason why Patient First is described here, the reason I think we're finding it such a helpful approach is because it just resonates clinically. It just makes sense. It's just, if I read all of this, if I look at this, is this any different to what I've been doing or trying to achieve for the last, however long I've been, a long time since I qualified, I've been a doctor for a long time. It's the right thing to do, but sometimes it hasn't happened, and sometimes the energy that comes from a very focused approach is invaluable.
Thank you. Councillor Edwards.
Thank you, Chair, and thank you also for this very comprehensive report. I was really pleased to see the sort of collaborative approach that's obviously been in place since the last CQC inspection, at the end of 2020 with health partners working together and there being a multi-agency approach. Certainly my view as somebody in politics that collaboration is the way to get things done, and it certainly seems like that's the case here, so that's really good to see. I was also really pleased to see, I think in section 4.2 on page 17, you discuss, don't use the language of targets, but you sort of discuss the executive team instigating a focus on ensuring that patients are seen, treated and admitted or discharged within 4 hours. And I think that's really good to focus on those kind of high priority things and to track them like you're doing electronically. And I guess just to echo Councillor Lammas's point about data, that's a kind of metric that I think will be really useful for this committee to see, you sort of say it's stabilised. It would be good to know what that looks like and ultimately where you want to go over time. And obviously, it sounds like there's a lot of really hard work that's been done on behalf of staff, so it's really good to see. One thing that's not covered in this, though, which I just want to ask a few questions on, in kind of as much as you can in your role, is just around the council, is around the MFT's finances. So my understanding is that extra money that's been available to trusts for COVID is now diminishing. And so it'd be good to just get your kind of high-level view of the state of MFT's finances, particularly if there was a deficit, what the kind of size of that deficit is. And also, do you think that there's enough capital funds to meet the backlog of repairs that I understand there is? Thank you.
So I probably won't go into the detail here in the finances specifically. I think that we, within the health sector, like everywhere else, we have a budget. We have to live within our budget, within our means. We have to prioritise. The only way that I know of being financially efficient is to improve quality. If you have a high quality service, you get things right the first time for all patients, that will mean that you will become financially efficient. If you do it the other way around, it's a very slippery slope. So when we talk about, so we have within our sort of patient first, there's a sustainability domain within that, and one of the areas, as well as looking at how we can be. We have a transformation and efficiency program that's cross-cutting across the organisation. As executives, we all have responsibility, and the areas that I'm focusing on, I'm absolutely clear that in terms of medical efficiencies and what we can do, we only do that by improving quality. So would I say that if we had infinite resources, that the health service would be significantly better? I'm sure with more resources it would be, but actually what we also need is the resources for social care, because if we had the balance of the two, we would be in a much stronger position. In terms of capital and backlog, similarly, we're given a capital allocation we have to prioritise, and the way we do that, and in fact we were having a conversation today about it, was that we prioritise according to risk. Where are the greatest risks? What do we have to do first? And it's all predicated around what's going to make the biggest difference to patients. So it would always be nice to have more money, but for maintenance and backlogs and so on. But what we are doing is making sure we use the resources we have as wisely as we can. There are opportunities, as you allude to, in terms of national funding, and the approach that we're taking is whenever we have a suite of projects that we want to undertake, that where we think that there's going to be potentially national funding, we consider whether or not we're going to apply for it. And often these calls for for applying for funds are actually at relatively short notice. So we have to make sure that we've got projects that are almost ready to go on the shelf, so to speak, so you can pull them down and use them to apply for that specific area of funding.
Thank you. I appreciate it's not necessarily, I guess, the kind of question that you would normally have to answer. I just think it would be good to have an understanding in terms of the financial pressures that the trust is facing. So it may be something that when Jane comes before us, we can delve into a little bit more. I guess including also, it's helpful to have an understanding of the kind of approach that you take, but really getting a greater understanding of exactly how much of a concern financial pressures are, and I guess how she will sort of engage with the board on some of those tricky issues would be really helpful to know in future.
Yeah, no, absolutely agree. And I think what I would say in terms of the so as all of us as executives, we have a responsibility for finances. I'm very clear as a chief medical officer. I have an absolute responsibility. It's something that's shared. It's not just the domain of our chief finance officer. I think in broad terms, the approach that we take is working again with the system of the ICS to ensure that the work for which we undertake, that we're funded appropriately, and that's an ongoing conversation and a supportive conversation with the system. And over and above that, we have to recognise, and again it goes back to because we are aware that there are the challenges within the community and so on, that we do have more patients coming to us than we would otherwise, and how that is resourced. That's the second part. And then the third part is that we have to be financially efficient, which for me equals providing high quality services. So that is a broad overview, but I probably won't go into any more detail than that. But we'll take that away and make sure that goes into the report for the next time. But thank you for that feedback.
Thank you. Councillor Adaway.
Thank you, Chair. Still on finances, resources. The NHS PACE settlement is regarded as inadequate by health unions, and some are balloting for strike. What do you think, what's your view on this, and what do you think will have an adverse effect or impact on already fragile recruitment and staff shortages? And is MFT any better off than NHS nationally for staff?
So I think that in terms of potential actions, we will work with national colleagues to understand and the impact that will have. I think that for us as an organisation, what we want to ensure that we do is make Medway a place where we can recruit and retain staff because they're happy and they want to work with us. I have huge sympathy for colleagues. You know, we all know about the cost of living and changes in inflation and the impact that has. And I think we need to ensure that we are sympathetic and we understand the implications therein. But it will be what will be working with colleagues across the system and nationally in terms of the approach to the specifics.
Thank you. And Councillor MacDonald wants a very, very brief question, and if the answer could be brief as well, please. And I'm not allowing anyone else to come back.
It might be quicker than that. It might be a very quick statement. It's just a couple of points for you, Chair, really. It is really important, Alison, I think, around the data. And it's about trying to find a happy medium, because we used to have reports here that would give us the finance. We were being told when you was at 62 million deficit, and went down to, and it was going down. It was good news that it was going down because we actually found out about a deficit in the newspaper. And, you know, I remember our reports would definitely have finance, would have recruitment, especially when you was doing external recruitment from abroad, which was really some really good outcomes for that. But you don't want reams and reams of paper, and I suppose that's what I was trying to say with the patient first. That's great, but it's actually the hospital we want to know about as well, and is it in a healthy place? So I think the finance question, not for you to answer tonight, but I would like a response on where we are with the deficit, because it was a very key challenge, and I think it would be good for us to know. But overall, I think for the main point I want to make, of course we support the hospital, that's why we're here, we certainly do, because let's not forget, it still overall requires, you know, it still requires improvement overall. So we've got a department that's good, and that was a great result, but the hospital still, and I'm sure you're on the right road, but it still requires improvement. So it's not that we're not supporting, but I would like to see some more detail, Chair, in future reports if possible, please.
No, the members are right. We did used to get that type of information. I believe it was 60 million at one time, going down to, yes. So we are used to having that in the reports, if that could be brought forward. And with that, Councillor Purdy for the recommendations.
Yes, well, first of all, Alison, we'd like to thank you for coming along and answering our question. And I think we all offer our congratulations to all the staff for what has happened, and we look forward to what will happen in the future. And we are all behind you, because for all our sakes, we're Medway people. We even deal with people in Swale. So we really do want the very, very best for everybody we represent. So we wish everybody the best of luck. Yes, we would like to ask for more data. I think that's very important because then we can all work as a team. We know what we're looking at. So I think that that would be a recommendation to bring that if we could have. And also the staff morale, again, something that's extremely important for us. But if we are able to visit the hospital, and Jackie said that we could do, and I know she invited David and I'm sure that other members would like to come. I think we'd all like that, wouldn't we? Because that's where we find out what the staff really are doing and what the staff are unhappy. Because they will talk to us, and they will tell us, won't they? We have experienced that before, haven't we, Dan? So I think that now that the hospital is open for business as normal, we all seem a little bit sceptical about what's going on, but we do understand. And as I say, we wish you the best of luck. Thank you. Yeah. Yeah. As I say, that'll all come in the data, won't it?
Well, no, can I believe we need the ambulance handover data, as Councillor Lammas asked for, and I think we all want the financial, the broad outline, please. If you could let us have that in a briefing paper. I just think all the data of a hospital might kill us to pick it up, let alone read it.
Just so it's like we don't have to go in as a patient.
Yes, but those two things definitely, please.
Yeah. No, and thank you for the feedback and the support. We are all in this together to do the right thing for the communities of Medway and Swale. So thank you for that. I think points around data absolutely understood, and maybe we'll work together in terms of the best approach going forward to that. But thank you for the feedback.
No, thank you, and as Councillor Purdy said, thank you for coming along. Thank you.
Can I escape? Thank you. Might not, if you don't mind. It's been a long day. I will.
So the one point I always forget, were those recommendations seconded? Yes, right. Thank you. That takes us on to agenda item 6, the adult social care reform, which is presented by Jackie.
Thank you. So the paper provides the committee with an overview of the new plan the government has set out for adult social care reform in England. The reforms include the lifetime cap on the amount anybody in England will spend on care, alongside a more generous means test for the local authority financial support. So that's when somebody pays towards the cost of their care. There are 4 key themes. So there's the care cap, the financial assessment or means testing, the fair cost of care, and then the changes to Section 18.3 of the Care Act. The reforms encompass, as I said, the introduction of the care cap, and effectively at the moment the government is stating that nobody will pay more than £86,000 for any personal care that they receive. That's subject to annual review. With regard to the financial assessment means testing, there have been some significant changes. So currently, if somebody has capital over £23,250, they pay for the full cost of their care or they self-fund. That's been increased to £100,000, so has significant implications positively for residents, but some challenges for the local authorities and councils across the board. And the lower capital limit is being increased from 14,250 to 20,000, which means that people will need to pay for care sooner if their capital is changed. There's a fair cost of care exercise taking place. So we were talking earlier on about the care challenges that we're seeing, getting packages of care and placements coming from the hospital and in the community. It's actually the local authority's responsibility to promote the efficient and effective operation of a market. So we need to do work around that. And part of the requirement of the funding reforms is that we complete a fair cost of care exercise where we work with providers to look at actually what would we have to pay to make the market sustainable. And alongside that cost of care exercise, we have to complete a market sustainability plan that demonstrates how we will ensure local care markets are sustainable and how we move towards implementing the reform. The paper goes on to talk about Section 18(3) of the Care Act, so that's a change recently that means anybody that is self-funding their care, where they pay the care provider directly, has the ability to ask the local authority to complete a Care Act assessment to determine if they are eligible for adult social care support, and if they are, the care cap kicks in, so that we need to start making sure that we're monitoring how much somebody will pay towards the cost of their care. And as you can imagine, if we are looking at how many self-funders there are in Medway or nationally, that then has an implication for the workforce, and we need to consider actually how many people, how much more resource we're going to need to recruit to be able to for us to complete those Care Act assessments and the financial assessments. The paper goes on to talk about the financial implications and the grant funding that we have already received and what we should be receiving going forward. And then I put some appendices in there just to give an idea of what actually would happen to people in specific circumstances.
Thank you, Jackie. Councillor Lammas.
Thank you, Chair, and thank you, Jackie. I actually found your report very interesting. It's one of the best write-ups of the forthcoming changes I've actually read today. I think it's very well laid out. I have two questions, if I may, Chair. The first is about local authority needs assessment. 2.6.5 says quite accurately that a person can only accrue costs towards the cap if they have been assessed as having eligible needs, and only the cost of meeting eligible care needs according to the Care Act accrues towards the cap. So this to me means that people are likely to want to request assessments or reassessments regularly in order to ensure that their most up-to-date needs are reflected in what can contribute towards their cap, i.e. if not, they have to pay for it themselves. So in my mind, that puts a lot of pressure on the local authority in terms of our assessment capacity. I note in 2.11, you mentioned the South East resource requirements for the implementation of not just this, but other work requires 250 financial assessors. And I note in the financial implications, you mentioned that only 25% of the grant funding of 674,000 can be used towards preparing things for market reform. So there's financial pressures all over. So my first question is what is your assessment of Medway Council's readability to take on this predicted increase in assessment pressure? And how long would people be expected to wait to get a complete assessment? I noted case study 3 in Appendix 1 gives a story of 1 month. Is that a target that you're aiming for? My second question, Chair, if I may, is about the fair cost of care exercise. Again, I have concerns about the resource allocation to do this exercise because I think this is a significant body of work. My question to you is very specific on this one. It is when you undertake to agree, local authority rates with the market, are you free to sort of do things whereby you have sort of fixed costs that aren't subject to inflationary reviews to protect the quotes that we can get on behalf of Medway residents against a predicted future increase in inflationary pressures? So the first question, Chair, was about local authority needs assessment capacity and how long people expect to wait. And the second question, Chair, was about how the council is going to go about fixing prices to prevent inflationary pressures eating away when they do their fair cost of care exercise. Thank you.
Thank you. Jackie?
Lovely, thank you. So I'll be very honest, at the moment, if we do not get additional resource, we will struggle to complete the Care Act assessments that we'll be required to, and the financial assessments too. As a rule, local authorities are seeing and suggesting on analysis that's been carried out with Trailblazers that they need a third of an increase in staff. So that's not just social workers, that is financial assessment officers, our brokerage team, the income team, it's a whole raft of stuff. So the challenge for us is, as the same as you all know, there are pressures in children's services. We've been able to recruit social workers. We're seeing the same in adult social care. So we need to look at what opportunities there are and can we do things digitally, but thinking about the fact that actually that doesn't suit everybody. So we're looking at a raft of things that we can do to be able to manage that. But if I could not sit here today and give you an assurance that we will be able to recruit the staff we need, and that's what we're planning and we're looking at. We're in that early stage at the moment. So how long would it take to assess? We should assess people. Well, so if somebody comes into adult social care, we should contact them within 24 hours. There's not the same time frame that you see in children's services, so we would complete an assessment that would take 28 days. At the moment, we're not getting out quickly. We'd want to be out within a month, but what we do is we look at the urgent cases that are coming through. So if there's a crisis, obviously we would resort and work with those individuals. And that's why we need to get that additional resource in place, all those digital tools in place. With regard to the fair cost of care exercise, I mean, we do give inflationary increases every year. We are always challenged about that, and we are particularly challenged at the moment because of the pressures, you know, around cost of living and so on and so forth. So there would need to be some really tight and careful thinking in our contracts about what we can and we can't do, and negotiation specifically. So it may be that in one provision it's quite straightforward to be able to give a blanket cost increase, but others where there are more challenging situations and people with more complex needs that we have to look at those as individuals.
Chair, can I thank Jackie for those responses? I think the pressures that she highlighted in her report are very stark, and these things need to be watched really closely by this committee going forward. But I'm really assured by Jackie's answers that she seems really on top of it. So hopefully Medway's in the best place it can be in implementing these changes. Thank you, Chair.
Thank you. Thanks, Jackie. Councillor Purdy.
Actually, Councillor Lomas has just asked what I was going to, because it is the work pressures and the staff and that. It's going to be huge for us, isn't it? But as you've said, you've started to put things into practice, and perhaps an update on it might be helpful for us so that we can follow the trail and where you're going, because it is.
So it is significant, and some local authorities have seen this as one of the most significant risks to them, as an organisation. I'm thinking about, we were talking about welfare of staff and so on and so forth. So we've got some workshops set up over the next few weeks where we're asking all staff to come along to talk about this, to really get an understanding of it. Because when you talk about talk about funding reforms, the care reform, it's very easy to think about the funding part, the financial assessment part. But actually, when you look at this, if we're seeing an increase in the number of people coming through adult social care's front door, that's not only about Care Act assessments, it's an increase in safeguarding referrals. It has a knock-on effect across the board. So we really want to get staff engaged to understand what this looks like, but without causing them any anxiety. So we're thinking very carefully about how we manage that.
Thank you. Councillor MacDonald.
Thank you, Chair, and thank you, Jackie, for the report. It's really good report. I think the only plea that I would make, actually, and being very careful with my other hats, the only plea I would make is that it will be a real challenge. You can see that. It will also be a real challenge for your voluntary sector as well. And going forward, there are plenty of voluntary sector organisations, I won't say, but there are plenty out there that would be helping, probably be doing appeals, probably be caught up in this process. Just a suggestion, it might be really good to reach out to those voluntary sector organisations, a bit of a summit or a bit of a talk to, because they do assist. And I know James will know during the COVID period, your voluntary sector across the whole of Medway assisted. They can assist even in this as well, because they will be doing it anyway. Or probably, if there's not enough communication coming down to the voluntary sector organisations, they can't help you. So it's about liaising, chatting, and I'm not asking you to set up another group, etc., but it'd be really helpful to set up something, because you'll be surprised how many people actually put their hand out to help you. Just going forward, it's only a suggestion.
So Sammy, who's our project manager, actually, she sent through the scoping document about everyone that needs to be involved, and there in the middle is the VCS. It's vital that we get everyone on board. So yeah, you're all, already considered.
Thank you. Councillor Turpin.
Thank you, Chair. And thanks very much, Jackie, for this report. It's really helpful, and I've got a good understanding, hopefully, I think, of what's coming in. And I just had some questions on the care cap as well, similar to Councillor Lamas, regarding the assessment time. And I'm just wondering, I don't know if there are issues at the moment with sort of families or individuals kind of arguing about when those assessments are made. And I just sort of saw this as a potential issue going forward, that there could be more disputes about, whether someone's eligible for the care that they perhaps have already put in place privately, and just sort of wonder, what your expectations of that is going to be. And obviously, as Councillor MacDonald said, there's going to be appeals and things. Are we going to sort of expect even more? And that sort of create even further work from what you're anticipating anyway. Just an understanding of the cap, is it a sort of continuous process? So I'm just wondering about if someone is sort of needing care, but then actually, and I don't know how often this would happen, but sort of improves to in their own health, that they actually don't need that care for a certain period of time, and say that was 2 years, when they sort of decided that they needed care again, would they start from zero, or would whatever they've paid already count for that cap? And then finally, in 2.6.4, that last sentence there, it sort of says, costs incurred before October 2023 do not count towards the cap in Medway. And I just wondered if that in Medway means it's different elsewhere. Okay, thank you.
So I think if you look at assessments, I think it's looking at the two areas. So when we are asked to complete a Care Act assessment, there doesn't tend to be the challenges around when they're done. People want them done as quickly as possible because they're concerned about their loved ones. I think the challenges that we'll see is more around the financial assessments and people paying for care. What we know is that if somebody is self-funding, they tend to be happier to pay the care provider directly than they do to pay the local authority. So I think we'll see some challenges in that area. And it's really difficult at the moment because when the conversations that are taking place with the Department for Health and Social Care, they've not ironed those sorts of parts out around the legalities. So we're still waiting for the guidance in that area to come through. I think from the appeals perspective, I think we'll definitely see an increase in that. And I think part of the challenge will be when you talk about eligibility, one of the many conversations we've had is if somebody is self-funding and they've made a decision to go into a residential care home themselves, and then we go out and assess them and determine that they're not eligible for residential care, actually the cap doesn't start ticking, they continue to pay that. And we don't know what the implications are then for somebody's money when their capital reduces. So that's the part that's still not been ironed out from a national point of view. With regard to if somebody has care and it stops, actually the cap, it pauses and it restarts. One of the challenges that we talked about recently is if a local authority is in a position where they've got the care cap up and running, a person moves to another local authority where they haven't got the care cap and everything up and running, what happens? How do you move everything across to somewhere where it's not, not working, and it almost feels like it will go back to zero. So we don't know how that part's going to work at the moment. And the other challenge for us is, Councillor Lammas mentioned the month. So from Medway Council's charging policy perspective, we have to get an invoice out to somebody within a certain period of time, that month, to enable us to charge. The government guidance about completing the assessments is saying, if we don't go out for 6 months, for example, because there's a huge backlog, and we go out and do that Care Act assessment, we have to start the care cap from the day the referral arrived, but we can't charge them because we're not allowed to backdate charges. So there's a general income, a challenge around income loss for the council in that area as well. I think and it's not just Medway, sorry, it's everywhere.
Thank you, Chair. So can I just come in on one other point? Yeah, thank you. I think you did actually anticipate a question there that I didn't ask, and you did ask about the backdating. So yeah, that's very helpful. The only other question I was going to ask was regard to if someone's put the sort of their own care in place privately, they get an assessment, they are eligible. Is there sort of quite strict rules on who they can sort of employ to carry out that care? Do they have to sort of fit certain criteria, the actual carer? So that's another thing I'm just concerned about. If someone's already got something in place and then they're sort of told, no, you can't use that they're not official, whatever, is there sort of quite strict guidelines on that? And I can wonder if that is going to cause upset as well.
So nothing sort of specific is coming out from this legislation to say it has to be ABC provider. But what we would need to look at is whether that person has met the criteria that we then deem them to be suitable to support the person. So I suppose if we're talking about somebody that's, I don't know, paying a neighbour, for example, to provide care for them, what we could look at if they were eligible was that would that person consider becoming, moving under the direct payment scheme? And so they can continue to provide the care, you know, they've got that familiarity, that trust and so on and so forth. But we think it would have to be somebody that was specifically known to the council, and we couldn't just do it for, you know, for all and sundry. But we would look to do whatever we could to make it work for the individuals.
Right, thank you. There's no other members, so Councillor Purdy.
Jackie, it was a clear paper, and I was reading and I thought, you know what, this is an easy paper to read, but it's not going to be something easy to carry out, is it? But yeah, I think we all agree we're in pretty safe hands with you, and good luck with it. So I don't think there was any other recommendations. I think we'd carried that out. So just thank you, Jackie. Thank you, Chair.
Is that seconded to note the report? Thank you. Thanks, Jackie. That takes us on to agenda item 7, pharmaceutical needs assessment, which David Whiting will introduce.
Thank you. So all local authorities, or there's a statutory requirement for all local authorities to prepare a pharmaceutical needs assessment every 3 years. Our last one was produced in March 2018, so we were due for another one by March 2021. But because of COVID, the timelines for updating P&As was pushed back, and we're now due to produce one by the 1st of October this year. The P&A describes the needs for pharmaceutical services in an area and is used by NHS England to control market entry. So, for example, if a pharmacist or a dispenser of appliances, or in some cases in rural areas a GP, if they wish to provide pharmaceutical services, they must apply to NHS England to be included on the pharmaceutical list. And they must prove that they're able to meet a need that's set out in the P&A. The P&A has to follow a fairly defined format, or at least contain a certain number of things, specified things, and we have that within our P&A. We also sought the views of members of the public while developing the P&A, and we got just under 400 responses, which is quite a large number of responses for something like this, quite a bit higher than other areas we're getting. So we're quite pleased about that. And these responses were considered in the development of the P&A. Once we had produced the draft, we then conducted the statutory 60-day consultation on this draft. We received a much smaller number of responses. This is normal, similar to what's seen in other areas, and it's probably not too surprising because it's a fairly large technical document, and the questions are quite simply about whether or not the P&A truly represents the need for the area. After this meeting, the P&A will be going to the Health and Wellbeing Board for final sign-off before publication. There are a number of findings within the document. I'll just pull out one or two of them. The current provision of standard 40-hour pharmacies should be maintained, especially in the rural and outlying areas. We noted that the loss of any of the 100-hour pharmacies that we have, if we lose any more, that could cause significant gaps in access to both essential pharmaceutical services and locally commissioned services, so that's important to keep an eye on. And there are proposals for future housing developments across Medway, and these could result in significant changes in the need. So we need to keep an eye on this need on a regular basis to identify whether any gaps appear. I'll stop here, and I'm happy to take any questions.
Councillor Purdy.
Thank you, David, and thank you for your report. I have deep concerns with this because most pharmacists are just a one-man band. You get just one pharmacist in any chemist. Even in some of the larger things of Boots, even they're pushed and they only have about 2 pharmacists. Now, that's a lot of responsibility for one pharmacist, yeah? Because nothing can come in or go out without him looking at, whether it's a prescription, whether it's a nomad tray or whatever it is, it has to be there. Nothing can take. Now, isn't this putting a lot of responsibility on one man?
Or woman.
I mean, don't mean to be sexist here, but yeah, a pharmacist.
So the P&A needs to describe the need of the population and what the pharmaceutical services are like. It's then up to NHS England, the Commissioner, to then determine where there are gaps and whether other pharmacists can come in. So that's an important point, but it's not the sort of thing that needs to be covered or is appropriate to cover within the P&A.
If you'll forgive me, I don't understand this, because this is something that we are going to be putting in for Medway pharmacists, aren't we? Yeah?
Right, sorry, James.
Sorry, James.
Thanks. Is it working? I think it is. Thanks, Chair. And just to clarify, so the issue is not really about, and I think we all accept the points that you've made, Councillor Purdy, in terms of ensuring that we've got appropriate access to pharmaceutical services within Medway. That's what the P&A does. So we as a local authority undertake the needs assessment, and I think David's made the point there that we've identified some specific vulnerabilities that we need to make sure that they don't turn into liabilities, i.e. that our population isn't able to access services. So part of the Health and Social Care Act 2012 gave health and wellbeing boards the requirement, it's our requirement as a local authority to set out the need, and that's what that does. And what that then does is it ensures that NHS England have to take into account our assessment to say, which is what David's actually saying there, we want you to consider, if a pharmacy says that they want to step back from providing provision, we can actually then, through the P&A process, challenge that to ensure that that, in essence, doesn't happen. But the points that you make around whether it's a single-handed provider or somebody like that, those are the issues around quality that NHS England need to take into account. What we are doing here is we're setting out the challenges for the system, but also the risks. And if somebody, for example, was to look to develop or want to come into the market, and that's basically on a commercial basis, and establish a pharmacy in X location, they need to take account of whether that's where they can go. And we might say through the P&A process, actually that's great, but where we need that provision is in X locality. So it's entirely in line with what you're saying. It's not a document that we're setting out to say, and actually we want people to do this. It's our ability to identify the risks and the needs in our population, and that then goes into the NHS system, NHS England, who are responsible at the moment for bringing pharmacists into the market. So it's entirely in line with what you say.
Can I come back, Chair? I think we've always done that with pharmacies anyway. We've always said, yes, we need one here, and then they would give them a licence, or no, it's not a suitable face. So that's nothing new, and I'm not concerned about that. What I am concerned is that we do highlight that there is an awful lot, especially for small, we don't have any large pharmacists in Medway. I think Boots is the largest one, and Lloyd's, but even so, they're not what I call a large pharmacy. And I just think this is putting an awful lot of pressure, and I hope that we will highlight this, and the Health and Wellbeing Board will do exactly the same. Okay.
Thank you. If I could ask a question, the report says that a very high percentage of people travel by car to go and pick up their prescriptions. It doesn't give the time that it will take for someone who can't drive, maybe has mobility issues, to get their medication in different circumstances. Now, I'm assuming I'm talking about rural areas, but I'm sure there's some in urban areas as well. What happens if somebody can't travel to get their own prescription? I know they can get them by post, I know they can be brought out to them, but we're not given the time that will take to arrange and generally happen. And some medications are quite important that they arrive quickly.
Yes, if I might, and then I'll pass to David. So the mapping that we do around the access and the ability for people to, whether it's by car or by foot or public transport, however they would get there, is entirely why we set that out. So actually then if you're looking at the issues that you've raised, it's then for the NHS system to say, well, actually, if there is an identified challenge in a particular locality, and so, for example, if we're looking at a rural locality, and you mentioned that where people may not be able to get out and about for whatever reason, then they need to think of other specific alternatives in order to provide the same level of pharmaceutical access as you've described. And I won't go into the points that we talked about before about the online pharmacies and things like this, but it's exactly as you've just described it, Councillor Wadley, that what we're doing is we're flagging the challenge. Now, the time element of it, and clearly it just does depend, because like seasonally, now schools are off and whatever else, people can get from A to B, in most cases, a little bit quicker. But the generalities that you made around, do we have in our urban areas more challenges because people are using vehicles to get from point X to point Y? That's all, again, part of the process that needs to be assessed. Should the need arise where, for example, people who want to bring new pharmacies into that area, we might then say, well, actually, based on your business case and your plan, it needs to go in this location. And by the way, as part of your provision, you need to ensure that you can cater for X, Y, and Z. But ultimately, it's our job, which we've done, is to flag and to highlight that issue. Time mapping, David might be able to go into some of that, but your point that you make is a really good one, and this is why we need to have this debate. But that's why the P&A is there. David?
Yes, so we do have maps within the P&A showing the travel times by car and on foot. The majority of residents within Medway are within a 20-minute walking distance of a pharmacy. In the more isolated rural areas, most patients live within a 20-minute car drive of a pharmacy.
Probably not the best example, but if you're normally fit, you normally drive, you normally go to the pharmacist, you break your leg, you've still got other medical needs, you live by yourself, I would have thought it would have said that this report, how long it would take you to get your medication by post, or if it's a delivery driver brings it out to you, how long it would take a person in that situation to arrange to get that process, just those sort of issues, which, as you say, it's for a very few people, but they're the people with the specific need. Does that make sense? It does to me.
Yes, it does.
Yeah.
Yes, it does. And it's a very important point, particularly in terms of health inequalities. I will work with the people that we worked with who produced the report, and we will add a section on that.
I'm glad I've given you an awkward question, but thank you. Councillor Lammas.
Thank you very much, Chair, and thank you for the report. I have two quick questions. The first one is on electronic prescription service, and this is something that I use and benefit from massively. The report, all the data in the report is all about open hours, but of course the seamless nature by which people can now navigate and get prescriptions and get them back massively affects the service provision in its entirety. So I wondered to what extent is the true impact of the electronic prescription service that's now used apparently by 86.5% of people in Medway already have on the actual ability for pharmacists to dispense medication quickly, and what impact does that have on Medway residents' health? I'd like to see some more information on that point, because that's a significant impact that's affected my health and for the benefit. Second question is what requirement is for this P&A there to be an assessment of vaccination capacity? I noted 7.3.1 talks about what happened during COVID. I'm surprised that only 6 pharmacies in Medway provided COVID vaccinations. If I've read that wrong, please do correct me. But to what extent is the people that this report is going to future-proofing Britain's ability and Medway's ability to vaccinate our population at short order if required in the future?
Okay, so...
I'll take that one, thank you. Great questions. And actually, I was just going to reaffirm some of the points that Councillor Wildley was making in terms of access and timings, because your point around some people, because of the way in which they interact with their clinicians, because that's ultimately the way in which, whether it's an urgent need, whether somebody will then dispatch something by courier or arrange for a drop-off, because a lot of primary care facilities will use that, depending on how they do it. You've got a collection system and things like this. So the issue about what services pharmacists can do is a really important point. The bit about vaccination, you may have seen in the headlines of the news, that particularly around seasonal flu vaccine, for example, or the COVID vaccine, that the management of that programme is moving towards the UK Health Security Agency. So some of the contractual bits, because this is back to why certain businesses and pharmacists, in most cases, are businesses, will deliver a service or not is down to a contractual arrangement. And that is a debate which happens within the NHS. So the NHS contracting team that deal with pharmacists will then say, right, we're going to put out a contract. They'll have a national negotiation with the National Pharmaceutical Committee, who will negotiate with central government in terms of what they would want to do, and then that plays out. And then at a local level, pharmacists can make themselves available should they wish to go along with the contractual arrangements that have been discussed. So in some cases, that's how they manage that. The other bit, though, is around workforce. And I think Councillor Purdy's point was really valid. In some cases, have they got the capability or the capacity, the staffing to do that? Is their facility amenable to enable folk to come in and to get vaccinated safely? And all those other kind of things need to be taken into consideration. So they're great points, and I think we do need to consider those in terms of when people... And remember, the important thing about this document is it enables us as a local authority to set out what we believe are the issues impacting on our population. What it doesn't do is enable us to then second guess what some of those contractual discussions will be, what the results of those will be, that then mean that locally some pharmacists will or will not make themselves available as any, it's same in primary care when you put out an enhanced service, for example, so GPs, other folk can deliver additional service. They can opt into that or they can opt out. But you make some really good points around that, and the capability points, I think, in the document, because one of the assessments that you'll see is what they currently do, how many hours they open, what they offer, those types of things. We can do that, but what we can't do is second guess, unfortunately, some of the debate that happens centrally and nationally about what services will be made available to pharmacies. But I can tell you the way in which the integrated care strategies go in and the new transformation programme is there is more of a reliance on using pharmacists to do a whole range of other things. So there's more of a likelihood in the future that they will be doing vaccinations, that type of stuff.
Thank you, Chair, and thank you for that answer. That's my point pretty much precisely, is that things like electronic prescription services, the range of services that our pharmacies use, these need to have material weight in this document in order to be put forward to the decision makers. And I'm sure that you have that, but hopefully it can be reflected in this document, because everything's all about open hours, and open hours is only one piece of the puzzle. But what you said has reassured me, so thank you.
Thank you. Councillor Turpin.
Thank you, Chair. Yeah, my sort of questions, comments is similar to Councillor Wildey, actually, with regards to the rural areas. And, it's a concern for me as a Strood rural councillor that sort of reading in here that, most are within a 20-minute drive. But what if you don't drive? And we need to be looking at sort of how accessible they are on sort of bus routes and things, if that's what people are going to have to rely on. And also sort of, it's opening times of pharmacies as well. If you're in a sort of more urban area of Medway, if it's open sort of, 9 till 6 and you're working, you know, you might be able to just about get there before it closes at 6. But if you're in a rural area, you're having to come back in to Cliff, for example, and you're going to really struggle to get to be able to get there for 6 o'clock. So that's a concern as well. These sort of accessible hours of these surgeries. So yeah, I'm just wondering if that's been looked at as well. Just the transport, the public transport and opening times.
Yes, so in the P&A we do describe accessibility by location, and we looked at means of transport. We looked at walking and by travelling by car. I can't remember if we did public transport as well. I'd have to look at the maps. So we can describe the need. We can describe the locations of the population, the locations of the pharmacy, and how long it takes to travel from the location of the population to the pharmacies. And then that gets taken into consideration by NHS England when they receive applications to open a pharmacy.
So could we just sort of definitely look at check on that with regards? With regards to if it has been looked at for public transport? So I think that's really important for people that, you know, if they can't drive in a rural area, it's going to be extremely tough to be able to get there. And it could be that they can set something else up with regards to regular medication, but I think it's particularly important for something when, you know, if someone's on, you know, they've just been to the doctors and they need to, you know, access the medication there and then. It becomes very important, and yeah, the working hours as well for those rural pharmacies.
I think that's covered on page 103 and 104. But sorry, you wanted to come in, James.
Thank you, Chair, and I think that the members, just in terms of the what's in the art of the possible, because the regulations as they set out, because I know members are talking about the or looking at how we can flex some of the opening hours and things like this, but these are all down to contractual requirements that are set out, which we don't have any direct control over. But the issue that you raise is a really valid one, and the methodology as to how, once a clinician has determined that somebody needs to require medication in whichever form, that again is a discussion and an interface between the clinician and the patient, and how then that happens, because a pharmacy, remember, is either they can do some of that, so that obviously some GPs clearly have got on-site pharmacy arrangements, and that's described in the P&A. But what we're not able to do, and this goes back to some of the challenges that we have, is then say, pharmacy X or Y, you need to be able to do this, this and this, because we don't have that direct control. What we do is say our population, which is the point that you're making about access, and what we're not, you know, what we can't stipulate is, because, you know, the regulations don't allow us so to do that pharmacists have then got to put in place an ability, if somebody's really urgent, to get, you know, medication to them within X period of time. That's going to be a decision that will get made on a clinical basis in consultation with whoever the dispensing physician, whoever the prescribing physician is, in order to then get the medicine dispensed. So just on that, and it might sound frustrating for members, but the P&A does not enable us to do that, but it does enable us to, as you've identified, highlight areas where we need to have concern because of the rurality of them, the built-up areas, and in particular, I think one of the positive things around the mapping that we've actually done is it does highlight for us where we need to be right, and actually in those discussions with our NHS colleagues who are able then to incentivise, to require, they're the people that can then do that. But from our perspective, what we do is we set out the need for our population and we advocate for that, but we're not the people that can then say, pharmacy X, Y or Z, you need to do that.
At one time, they always had an emergency pharmacist that could be called out 24/7, yeah? Does that no longer happen? Because that was a very useful thing to have, because as Councillor has just said, there are always going to be people out of hours, and if it is an emergency, then pharmacists could be called out, and I thought that was still in their contract.
They do, but I think I'm talking about two slightly different things. So one is the ability for us to require pharmacists to, you know, operate in a certain way, is one thing that we directly can't do that, but the provision of medication out of hours is actually something that they have to do, and that's one of the contractual things that gets puts in place. David can probably expand a little bit more.
I was just going to say also that there's the out-of-hours service, so that Medoc out-of-hours service, where they can provide a range of essential pharmaceutical products. Just coming back to Councillor Turpin's point, thank you, Councillor Wilder, you got to the pages more quickly than I did. On pages 103, there's a map showing access to pharmacies by public transport for morning weekdays. And then page 104, there's a map showing travel by public transport on an evening. So that covers both the public transport issue and the time of day issue that you raised.
Okay, are you happy with that? Yes. 2 quick points. Thank you for agreeing that paper's much better than... I would rather members, especially my vice chair, didn't jump in, but did go through the chair. But that's fine. Councillor MacDonald.
It's only a very quick one, Chair. A good report. I know it's very thorough. I suppose my question, well, it's always been a question we've had about pharmacies, is the longevity and whether they will sustain and whether some will close. You know, I speak to a lot of pharmacists in Gillingham, and it's very clear to them that the COVID clinics, the clinical part, is the big earner for them. It's with the Brexit prices of tablets, they're trebling in some areas or quadrupling compared to what they used to pay. So they all seem to be going down, which is a good thing. We do need the clinical areas, but they all seem to be going down that road because many are saying that is the only way that they will sustain their business. And it might be like a farmer comes and says to you, they're always poor. I'm not sure, but that's what I have seen, and I've actually seen others that have sort of opened up another pharmacy and it is purely clinical and it's ready for their COVID vaccination. So we do lose pharmacists, that they do retire and move on. I'm just wondering whether that has been a small piece of this work, looking at with another 30,000 houses, for example, coming down the road. You know, have we got that sustainable approach to pharmacists? And I suppose it's what Councillor Purdy was saying. You know, we have a few. We don't have that many. And have we got a long-term plan, or are we looking at that plan if someone was to close and move on?
If I might, Chair, because this goes to the heart probably of the challenge that we face, but it's a similar issue around workforce and capability. One of the benefits of being in Medway is we've got, I'll point the laser that way, I think, the University of Kent, and we've got our own School of Pharmacy. I sit on the board of that, and we've been having some really good discussions around increasing the flow and retaining people within our space. So we have actually got within our gift the capability to produce more local people. That goes back into our skills agenda, encouraging, and you know, Leanne and I and Jackie, we were having a session today around planning around what are the needs in Medway, how do we actually deliver for our people, and one of the things around ensuring that we've got the right people coming through to serve our population and understanding what that looks like is pretty pivotal. So I would just go back and say we can only do, in essence, what we can do to create the environment within our space, which is what we are doing to encourage, and this is a message for all members, I would suggest, and anyone sort of dialing into this sort of committee today. We've got fantastic opportunities for our children and young people to look at their careers and their career choices, regardless of whether they want to go as an engineer doing stuff or into health and social care. But if they want to be pharmacists, we've got a fantastic school which will cater for their needs and help them with their career development. You know, the whole thing we were talking about the hospital earlier on, there's placements there, not just in the acute setting, but we've also got community stuff. And when you go, because obviously we've got lots of different ways in which pharmacies can operate. And I would just urge members to remember that bit and to think through how we can support anyone who's interested in a career in whichever area it is, but equally in pharmacy, that, you know, it's there, they can get in there and hopefully we can retain them, which will not answered totally the point that you made about the commercialisation of pharmacy as a business, but actually what we can do is to create pharmacists.
Thanks, Chair. Just to come back, and I agree, John. I mean, obviously they've got premises to operate out of, and if it's great to have the School of Pharmacy. I suppose I'm looking at where's the fine line with regards to a pharmacy. If you're going to a pharmacy, you can get clinical because that's what they're pushing to. It should be. I don't know what the cut is, whether it's 60-40, 50-50. I don't know. But if they're pushing more clinical, and then you're going in with your prescription, but you can't get your asthma pump, you can't get because they can't get hold of it. It's not in stock, or certain tablets. You know, and it becomes an issue where they're not getting stock in, but they're concentrating more on their clinical, which is important. But where's the fine? Where's the cut on that?
So I can't give you a proportionate cut now in relation to how they operate, because clearly they're all different. And we've got healthy living pharmacists that do a whole range of holistic services and outreach, and there's a whole range of things that they do. But what I can advise is on the discussions that we have been having, not least in relation to that rounded nature of folk who go into pharmacy and their ability to interact with the community and not just look at, because a lot of it is very technical. Being a pharmacist, you go through a lot of training and you come out of that and you're well skilled and versed to do things. But we can build on the aspirations that we've got to use those settings to do that wider well-being stuff. If you look at, and you know this yourself, Councillor MacDonald, in relation to social prescribing, the ability for them to act and to support. Pharmacists are generally speaking the place that a lot of people go. They're not going into other settings, whether it's for repeat prescriptions or minor ailments, stuff over the counter. And that's the opportunity that we've got to use those. But it is, as you've said, a challenging position, and we've got to only do what we can do through our P&A, which is to set out that challenge and then use the tools, hopefully, that we've got within our gift. And you mentioned those. We can do the place shaping bit, planning. We can sort out facilities. We can do that kind of stuff. We can sort out people, but equally, there's some macro challenges for us there around the models. And I think the points that was referenced around online services and stuff, because some people really just want to use those services and they're really good. But what we've got to do is to remember, as you've said, that there are other people that need to access face-to-face services where they might need more time to have a discussion about other things, and we've also got to cater for that as well. Exactly.
Thank you. Councillor Edwards.
Thank you, Chair. I just wanted to pick up on some of the kind of future-proofing contributions that members have already made. I think we need more prescribing pharmacists as well, and I know that the existing ones also need training and more support, maybe, because I know that some have sort of fallen foul of some unannounced inspections. I know that there was one, not in my ward, but on the border of my ward, Rochester East, that is used by Rochester East residents that fell into that category. And we know that the role, as other members have said, of a pharmacist is changing. It's developing. I'm certainly aware that the UK's drug regulator, the MHRA, announced in July, that some types of oral contraceptive pill can now be administered over the counter at pharmacies without prescription. So that kind of thing is going to be, I guess, a challenge for the role of a pharmacist. So I guess it would just be useful, you've sort of talked about it a little bit so far tonight, but, how will you be future-proofing the role of pharmacists in Medway? And a suggestion really, is there a space for the ICP to work on this, for example, more training places, as I understand that pharmacies do have a seat on the ICP board?
Okay, so some great questions. So I go back to the whole point around when you're talking about regulations, and you mentioned the expanding role of pharmacists and training, that would again fall down to the pharmaceutical committees and their CPD programs and whatever it is that's going to come out from any further discussions at central government around what the expectation would be in terms of using pharmacy. So that's something, and it will link into some of the discussions that we've had around the future training programs and what that curriculum will look like. I can't remember, the P&A is not about that, because we're going into workforce bits which are slightly outside of scope of the pharmaceutical needs assessment, because we're now looking at, and then what do we do with these people? But it's a good discussion for us to have, and perhaps one to come back to, because actually what you really need, I think, in terms of members for assurance about the future proofing of pharmacies, to talk to the Pharmaceutical Committee to get from the horse's mouth what the challenges are at a local level that they face, and that would perhaps enhance and enable us to think through what that might look like in terms of support or additional challenge that we might need to put into the system. In referencing the Integrated Care Board, I don't think there is a position, as you've just described, like a pharmacist who sits on the board in that kind of respect, and Leanne might be able to tell me that I'm lying to make friends, but I think there is, in the Integrated Care Partnership element of that system, I definitely know that there is pharmacy in there, because I definitely know that, because the board is slightly different to the whole system, and in terms of how they work, I think it goes back to Councillor Lomas's points earlier on. We are developing the integrated care strategy, and we've got a period of time to do that, and that's something that will be discussed, I think, later on when we come on to the work plan. All of those things and how they all move and interact together are things that we've got to take in the round, and pharmacy's got a real key point to play, but tonight, unfortunately, in terms of that, I think the P&A won't answer that question for you, because it's not that bit of it, but it is linked into how we can manage that process, and we can come back to it, because what it does is it gives us levers, and it's really important. So if somebody wants to hand back their contract, we can say no, we can, because any kind of things like this, we can then require something to be done in order to ensure that that provision is not taken away, and that they're the kind of levers. If somebody wants to come into the market and they say, right, you know, if we've got a highly populated area or a place that's got lots of pharmacists, and remember that the national regulations need to catch up with some of the innovations that's happening in pharmacy, and that's an important point that we're hearing today, because it's not just about opening hours and things like this, it's about other things. But if somebody wants to come into the market, that gives us the ability to say, actually, yeah, great, but you need to come into the market and deliver these types of services in this area, because that's what the P&A says, rather than coming into this pit and trying to, you know, put another pharmacy on a high street where there's already about 5. So that's the kind of ability that we have got to manage that kind of aspect. But, you know, my views on the broader questions that I'm hearing about pharmacies, really to get the Pharmaceutical Committee in, or a representative from the commissioners, which might be somebody from NHS England or from the ICB, to actually set out what their strategy is for pharmaceutical services, which will then pick up your workforce stuff that you've raised, some of the flexibility issues, some of the innovation type stuff. That's where you'll get that, but you won't get that from the P&A.
Thank you. There are no other members. Councillor Purdy.
Thank you, Chair. And I didn't actually talk over you. I did say, is it okay, Chair, if I do that? I wouldn't dream of talking over you or go against your rules. I have too much respect for you, David, so thank you.
Thank you, Councillor Purdy.
That's okay. Now we go back to the business in hand, and I put forward, I think that would be an excellent recommendation. I don't know whether members agree with me, that we did speak to the as James said, yeah? Would that be something that members would agree to come back to the board, or do they think, no, you're not interested in?
Could that be arranged?
Yeah.
I think we can have a conversation, because it's who's best placed to answer all of those questions that are being flagged today, and I think strategically it would probably be somebody from the ICB or the NHS England who would be able to then answer those challenges, Chair. But you may also want to hear from, because the Pharmaceutical Committee would be the people that say these are the challenges that we're facing.
I think the Pharmaceutical Committee would be a good people to hear from, because I am concerned that this will put pressure on some of our small pharmacies. And yeah, there is money to be earned for them, and we want that, and we want things to change and expand and for the better. But I have concerns with it personally. I can't speak for other members, but if members are agreed with it, I put that forward as a recommendation. Yep, thank you. And just to say thank you, David. I know you've worked extremely hard, because there's a lot of reading in this. Yeah, thank you.
Thank you.
Thank you. Is that recommendation seconded? Yes. And agreed. Thank you. That takes us on to agenda item 8, Kent to Medway Adult Learning Disability and Autism Collaborative Report from James Harman, please.
Thank you, Chair. So I'll take the report as read, but I will pick out a few key points if that's okay. So I previously came along earlier this year to present the proposals to members around the improvement plan for services for people with learning disabilities and autism. And as a result of that, I was asked to bring back a short update paper in the summer and then a fuller paper in the autumn. So this is the sort of middle ground of those updates for you. So the sort of key developments and points that have happened in the meantime, there is one bit of information that I can add that we didn't include in the paper because it's only recently been finalised, but a strategic post/director has been appointed for Kent and Medway. Leanne, I believe, was on the interview committee, and that's a person called Marie Hackshaw. She currently works for KCHFT. Personally, I've worked with Marie for a number of years. We work very closely on the COVID response, and I think she'll be a good appointment. So I think she starts next week, I believe. She's been released early by KCHFT to start the role early. And just a reminder that is a joint post across Kent and Medway. So she will be spending some time with us over in Medway, particularly in Gun Wharf, that we're trying to finalise at the moment. Other key developments, so there's now a programme management unit been put in place across Kent and Medway. So it's a virtual one. It's not about sort of people sort of being removed from their particular posts and into a central unit, but it's a virtual programme management unit. So that's really positive. The delivery partnership is now up and running fully. There's a strategy that I think I mentioned last time I came, which is being led by users with lived experience. So we're very close to having a draft strategy in place for that. They're looking at that going out for public consultation at the end of September, which will help inform some of the sort of direction of travels and what we want that partnership and collaborative to achieve. And that there have been some users with a lived experience from Medway as part of that working group. And they are also regularly on the call. So a lot of the working groups that we have around this area of work that Jackie and myself and others in our team sit on, there is virtually always a user with lived experience, which is a really good bit of practice. And I suppose finally, and I know it's sort of a question that regularly comes up, is are we having our say as Medway? I think we can confidently say yes. Leanne was sort of core to the appointment of that role. Jackie and myself sit on lots of groups, and if we can't attend, then lots of our team will as well. So we're very, very well represented and make sure that we get the views of Medway across, and that we're listening to our service users and making sure that our systems and processes link in with anything that's coming across as a system-wide approach. So they're the main sort of points that I just wanted to highlight, but clearly I can take any questions. I believe the full paper is due back in the December board, I think, Michael. And we have sort of tentatively asked whether Marie would come along to that, but that's down to members to decide whether that would be useful or not in that joint post, because again, I think that was an action from last time to potentially having that post come and sort of answer as to where we are in the current scheme of things. So I'm happy to take questions, and I'm sure Jackie and Leanne can answer anything that I might not be able to.
Thank you. Councillor Lammas.
Thank you, Chair. Two quick questions, if I may. The first one is, can I just have some clarity on 3.4 about Medway not attending all meetings, which is now, it says, been resolved. I remember when this report came to this committee, one of the things that Councillor Purdy and others mentioned was we're worried about dilution of Medway voice, and we wanted to be assured that Medway's voice would always be represented when we go to this bigger, higher Kent area level, and so that our service offering and the acuteness of our needs felt in the room and not diluted. So could I have some clarity on what 3.4 is talking about? And as this is about the improvement of social care outcomes for adults with learning disabilities and autistic people, could I just have an update on what is the current waiting time for EHIC plans compared to where we were last time we read this report? Because something that I'm continually concerned about is that wait, because it leads to, that's what people need to open access doors to get the support they need in schools. So are we moving in a positive direction since when we last spoke about that a few months ago? Thank you, Chair.
Thank you. James? Jackie?
I can get the button on, I'll answer, sorry. So from a meeting point of view, I can assure you that, and reassure you that we are attending. So in the document, it talks about the governance structure. And if I look at the meetings, actually, I attend the provider collaborative, the delivery partnership board, the oversight and monitoring board, and so on and so forth. As James attends, but also 2 of James' team members are with us. There tends to be 3 of us, which may seem like a bit of overkill, but actually because of the need for Medway's voice to be heard, it's really important that we're there. And it does mean that if I can't attend, that we're keeping in the loop with that. I've been emailed so that from a group of leaders that we're going to have some development days together so that we can look at how we work together across the different organisations, and they've been being set up within the next couple of weeks. It is challenging. There are an awful lot of meetings, but because it's so important, it's really vital that we're part of that. And James mentioned earlier on about the voice of a person with lived experience. We had a meeting with BMIX recently, where we've agreed to be, really proactive, working with them so that we make sure that Medway residents' voices are part of this, because it would be very easy for it to become very Kent-focused. So we're pushing in that direction, and I'm really encouraged because BMIX actually said to us, we need to make sure Medway residents are involved. I didn't have to make that comment and that suggestion.
Okay, are you happy with that?
Yeah, and the update on waiting times for EHIC, please.
Yeah, so with EHCPs, I don't have that data to hand because that's obviously linked primarily to young people, but we can certainly feed back to members on what the current waiting times are for EHCPs. But yeah, I haven't got it to hand, I'm afraid.
Can we have that in a briefing note? Or?
Yeah.
Yeah, cheers, thank you. Sorry, did I see a hand? Councillor Edwards? Yes. Councillor Edwards.
Thank you. Just a quick question that relates to, I guess, how the process is being managed. So I know that there's it talks of a whole system transformation, the paper, and I certainly know that can sometimes be fraught with problems. So I'd just be interested to know, I guess, how you're managing the kind of service transition arrangements to make sure that nobody is falling through the gaps. I think the eating disorder service, which was transferred to a new provider, was an example where some things, maybe didn't work so well. So interested in how we kind of avoid that kind of scenario in this programme.
So yeah, I can pick some of that up. So I think it's less about moving services from A to B, and it's more about the fact that there is one unified offer. So we know, particularly across Kent and Medway and even different parts of Kent, that depending on where you were, what hospital trust you were linked to, services were delivered by different organisations. It was about having a standard level of practice and care, and that all of those things link up together. So it's less about lifting and dropping services in that way, but it's about all of those coming together and coming under that strategic lead provider, which is KCHFT, who will sit across there. I think we're very confident, and I'm going to look across there, that we know exactly who our cohort are. Certainly I ask my team that on a regular basis, what are the numbers? Are we sure we know everybody that we need to support and help? And I believe as a system we do know that. It's just a case of getting all of the different services together, those pathways really redefined, redesigned. So that's your statutory pathways, your NHS pathways, your social care pathways, also the pathways into voluntary sector organisations as well, because Dan picked up earlier, they're a key part of delivering some of these services as well, and it's just about having a system that is less fragmented, and that's I think what we're trying to achieve overall, rather than actually saying we're going to transfer all of the services into one organisation or away from Medway or away from Kent or whatever it might be.
One more if I can. Thank you. That's really helpful to know. I mean, in terms of making sure that nobody's falling through the gaps, then you said you're talking to lots of people. Is that being done in a strategic way through kind of regular, maybe officer level meetings across the various key parts to make sure that that's being done?
Yeah, so as system-wide, yes, we we probably have too many meetings, I would suggest, Jackie, at the moment, but we're in that sort of forming stage. But I know Jackie and her teams, you know, you're fully aware of who we've got in Medway that needs that support, and that's being fed into what we're looking at. So I would be very, very, very disappointed and surprised if anybody was going through that system, because an awful lot of the preparation work has been done around making sure that we've got accurate data sets, that we know who people are, what their needs are, what their diagnoses are, and what sort of support they've been offered so far.
Thank you. Did Jackie, do you want to come in?
Yeah, thank you. I think I just wanted to also mention, from Marie's point of view, one of the discussions that we had 2 weeks ago was around the fact that the need for social care to be really on the partnership at a level setting. You know, there sometimes can be a really big focus on health, and actually the social care element gets left behind. And I was really assured Marie was absolutely on board about how do we make sure that we are working together and given that real focus around the services around the individual, and that's really refreshing, because we do see sometimes that isn't the case.
Thank you, and Leanne would like to come in.
Just to assure you, the programme director post is jointly managed by KCC and Medway, so that's always a risk, but there's also a benefit. I mean, there's lots of meetings, in my view, because Kent has an infrastructure that can support those meetings. We don't necessarily, and that's why you'll see comments like that sometimes it is hard to keep up. But that program director post, I jointly manage that person, so we've tried to sit it in a part of Medway that our partners can be under no illusion that we are a significant and equal partner, and that's the way we're going to carry on.
Can I ask, I used to sit on something else, and at joint meetings with Kent, there was 6 different groups in Kent, and each group talked about the same important issue. So as Medway representatives, are you finding you're having the same conversation more than once?
Yes.
No, that's fine, just so I understand what might be happening. Thank you.
Thank you for the report. I'm looking forward to it coming back in December, because I'm sure that we all have concerns about this. And I have said, and Councillor Wildey always agrees with me, we can get swallowed up by Kent, whether we like it or not. And we've experienced it over the years. So, anyway, we have a report coming back in December, and I'm sure that will be,
We've also asked for a briefing on the timeliness of children being assessed for, and could that also go, Michael, to the Children and Young People's Committee? Right, thank you.
Yeah.
Thank you. Is that agreed? Thank you. That takes us on to the last item for the evening, the work programme. So over to Michael.
Okay, thank you, Chairman. The report sets out a number of changes to the committee's work programme, which are recommended. Just want to draw attention to, there's an item in the work programme at the moment in October to look at the Women's Health Strategy. That's the government's Women's Health Strategy. The advice from James as Director of Public Health is probably best to deal with this through the development of the new Integrated Care Strategy. And following further discussions, we suggest could look at this in December as part of the committee's consideration of the developing Integrated Care Strategy, as we think the timings would then work out better. and members are asked to agree that as a way forward. Thank you.
Could I ask James, well, if members could look at 3.3, but if James could also talk us through that.
Thanks, Chair. So the context of the ask is basically where we are now in the process of developing the integrated care strategy for Kent and Medway, and in addition to that, refreshing our joint health and wellbeing strategy for Medway. We're in a position where we can actually ensure that the issues that members have flagged around, are we doing enough to support women? Are we actually able then to bring forward within the actions that we, as a committee, as members, to get assurance that the actions that are being delivered are going to change the life chances for our women, address or redress some of the issues that we've noticed over the last few years. The integrated care strategy is the way in which we will do that. We will have a chance and opportunity, because the first cut of it needs to be ready for December this year, but then we've got an ongoing process where it can then be refreshed. So you'll get a first chance to look at it. Is it telling us what we actually want it to do? Members will be able to comment on that. We can feed that back into the process, but it won't be ready clearly until December, because we only got notification of the framework of that in the last sort of 2 weeks, and of course we're now from central government as to what needed to be in the actual strategy in itself, and clearly we're now just putting all the steps in train to deliver the work that's required. So a December deadline, Chair, would give us the ability to pull the work together in draft form for members to be consulted, of course, and you'll be consulted in any event, hopefully outside of this committee, but then for the committee to take stock of it, make your comments, and then for that to be fed back into the process.
Are members happy with that approach? Thank you. So, Michael, back to you if there's anything else.
Not particularly. Just to highlight we set out the timescale, well, the indicative timescale for the GP Access Task Group, and that's it. That's in section 5 of the report. Just to draw members' attention to that. Thanks.
Thank you. So, Councillor Purdy. And with that, thank you, members, and see you all soon. Cheers.